Today we have one of the gods, at least Dr. Seyfried, I consider you as one of the gods of cancer research. I don't know if you would accept that as a compliment, but that is the compliment I shall give you. But yes, Dr. Seyfried is on board with us. How are you doing today?
I'm doing very well, thank you.
So, Doctor, first of all, the most important question here is, how did you get into this world of research? What's your backstory? Let's talk about that.
Well, I mean, I've been working in biochemistry and genetics for over 40 years. And my doctoral degree from Illinois and my master's degree from Illinois State University, University of Illinois and Illinois State, are all in genetics and biochemistry. So, and then I took that further into Yale University, where I did a lot of work on epilepsy, genetics of epilepsy, biochemistry of epilepsy, biochemistry of lipid storage diseases like Tay-Sachs disease and Sonhoff disease. And you know, we were working on gangliosides in cancer. These are complex glycosphingolipids that are also abnormal in cancer cells. And wondering if cancer could provide us with some understanding of these molecules. But they are the same molecules that also accumulate in the brains of children with Tay-Sachs disease. So we had been working on that. And as I said, I wrote a grant at Yale many, many years ago looking for the ketogenic diet as a therapy for epilepsy. We had some really good epilepsy models in mice. And they said, well, that's kind of passé. Nobody's interested in ketogenic diets anymore. That was like big in the 1920s and 30s. And then in epilepsy, you know, the drugs have moved in, and they seem to be the preferred way to treat people with epilepsy. So I kind of dropped it. And that was, I think, in the late 70s. And then I didn't take up the ketogenic diet again until one of my students went out to California or to Seattle, Washington, and had a meeting with Jim Abrams, who started the Charlie Foundation, which is a foundation focusing on ketogenic diets for epilepsy. And the person, my student Mariana, came back and said, oh, the ketogenic diet is really big. This guy Abrams, a Hollywood guy, wants, because his son Charlie was impacted significantly by epilepsy and was very sick, almost died until he went on the ketogenic diet. So I said, well, you know, maybe we'll give it a try. We started it here at Boston College back in the late 1990s, mid-1990s. And then it became clear that the ketogenic diet was operating through calorie restriction to stop the epileptic seizures in our preclinical models. And then I became very active in the ketogenic diet workshop for the American Epilepsy Society. And I used to run the workshops there for several years at that society. And everyone was a very small group of people, maybe 10 or 12, that were really interested in how ketogenic diets could manage epileptic seizures. And then, of course, Jim Abrams started the Charlie Foundation and exploded interest in the ketogenic diet as a therapy for epilepsy. And then we started it on some of our brain tumor models that we had here in the lab, mainly because we found that calorie restriction was the underlying mechanism for ketogenic diets, and we knew that calorie restriction could also be effective against cancer. So we just moved the ketogenic diet restricted into the cancer realm, and we found out how powerful it actually was. And we could never really figure out the mechanism by which the ketogenic diet could stop epileptic seizures, and that's still a very active area of research. But how it could stop cancer was so much more clearly understood once you understood that Otto Warburg's theory of cancer was the correct theory. And therefore, then you could explain very easily how the ketogenic diet could manage cancer. And then from there, it was just, you know, momentum on the whole thing.
Okay, so how do you guys figure out what kind of ketogenic diet you are supposed to use? How do you devise it? Because I've already asked this question to Dr. Dominic, who was on our podcast, but I would like to throw this question right back at you.
Yeah, so, well, this is a very good question, because at first it was just measuring the ratio of fats to carbohydrates plus protein. And usually people would go a 4-to-1, 4-part fat to 1-part protein carb, or 3-to-1 or whatever. And nobody really paid much attention to the types of carbs, the types of fats, or the types of proteins. It was just more the ratio. It wasn't really discussing, you know, what kind of proteins or fats might be good. So we took that to a new level. We actually patented a formulation that we think is actually pretty effective. for how the various ratios of different kinds of fatty acids may be helpful. And I think that the world of ketogenic diets is just exploding only because there are so many ramifications of new combos of fats, carbs, and proteins that could all put a patient in therapeutic ketosis, but coming from different origins and combinations of these different metabolites and nutrients.
Yeah, and that's one thing that confuses me as well is how do you deduce, okay, do I want to have this much saturated fat, this much omega-6?
Yeah.
So,
well, that's why we developed the glucose ketone index as a biomarker system to help. Well, it was done first for cancer patients, but then it exploded into, all these young people that want to stay super healthy, that have nothing wrong with them. They just want to see how low they can get their index as a kind of a challenge. But for us, it was having a ratio of ketones and glucose millimolar in the blood of about unity, 1.0, where in other words, the amount of glucose and ketones is about unity. And of course, if some patients can get below 1, where ketones are actually a greater source of energy in the blood than is glucose, then that could even be better. And some of my students have gotten considerably. People who are healthy who don't have cancer can get into these metabolic therapeutic ketosis zones quite easily. I don't want to say it's easy, but it's certainly easier than the cancer patient can get there. So this has now become an organization. Heads Up Health has adapted our GKI calculator, and I told them it was originally to be used for cancer patients, but now I see more healthy young people are using the GKI to see how much in therapeutic ketosis they can get, and this then will address your question about what you should eat to get into this zone of therapeutic ketosis, because what one person might eat may be different from what another person will eat, but they're both in the same level of therapeutic ketosis. So that then becomes the biomarker.
Okay. So could one be bold enough to say that if I remain under a certain threshold, it can have cancer preventative sort of effects? Could these claims be made?
Yeah, I think so. I think so because we know what the origin of cancer is. The origin of cancer is damage to the respiration, the mitochondria in the cells. Once the damage to the respiration becomes chronic, the cells then can't respire effectively and they begin to ferment. So the fuel for fermentation is primarily glucose and glutamine, the other amino acid that can be metabolized to glutamate, to alpha-ketoglutarate, and it goes through and it can be fermented in the TCA cycle. But these are the fuels that will be driving the cancer. So to prevent damage to the respiration, you want to maintain your health and vitality of the mitochondria. And one of the ways to do that is switch them from glucose metabolism to ketone body metabolism. Ketone bodies are a super fuel, as Richard Veach from the NIH had described. They increase the energy efficiency, the delta G prime of ATP hydrolysis, which I know is a complicated term for a lot of people that are into bioenergetics. But basically, it's an equation that shows the efficiency at which ATP is made in the mitochondria. And you produce very few oxygen radicals when you're burning ketones in the normal cells. So cancer cells, because they have defective respiration, can't use these ketone bodies. So consequently, once you have cancer, then you can starve them. But before you get cancer, if you want to prevent cancer, then you just keep your mitochondria very healthy. Now, how do you do that? Well, you can keep your GKI, glucose ketone index, at 1.0 or below for about a week. If you can do that, that'll energize your mitochondria and make them very healthy. And if you have defective mitochondria, you can actually get rid of them through an autophagy mechanism, self-digestion within the cell. So there's a lot of ways you can prevent cancer. But I have to be honest with you, in our society today, where we have massive amounts of very tasty, high carbohydrate foods, it creates a difficult situation for many people to stay into these zones for too long. But I don't think you have to stay in these zones forever. Like Dom, my friend Dom that you mentioned, Dom D'Agostino, he stays in therapeutic ketosis most of the time. So, and some people can do this. I can't do that, but other people can do that. So, but I think periodic fasting or ketogenic diets can go a long way in preventing cancer because they keep your mitochondria healthy.
If you want to learn how to implement the ketogenic diet and the Press Pulse protocol into your cancer management, just visit school.com/keto for cancer, the new community by our research analyst Johnny Rockermeyer. Within this new community platform, you can connect with other patients and learn from their experiences. You can also just search through the posts other members have already made. You will have access to our classroom section as well, which provides practical advice and tools for the best results. These sections cover all parts of the Press Pulse protocol that you should implement. Starting with the general scientific concepts by Dr. Thomas Seyfried, we will show you how to start the ketogenic diet, including which foods to choose and which to avoid. Additionally, we prepared a list of doctors specialized in metabolic therapy, as well as details about glutamine inhibition and hyperbaric oxygen protocols. So, take a look around at school.com/keto for cancer.
Awesome. So what actually causes cancer? This is a running question everywhere. What do you think is going on over here? I know it's a very general question and it encapsulates a lot of different cancers, but what could be some of the factors here?
Well, I mean, it's anything that will chronically damage your mitochondria. So, and that's referred to as the oncogenic paradox. Because Sid Mukherjee, in his book, The Emperor of All Maladies, struggled with this same concept on page 285 and 303 and some other parts of his Pulitzer Prize book. He was struggling with the same thing, and that is, how is it possible that some people can get cancer from one thing, another person gets it from something else, and yet what is the common underlying pathophysiological mechanism that would possibly link exposure to a chemical carcinogen, exposure to radiation, exposure to a virus or some rare inherited mutation? What are they all doing to cause cancer in the person that has this affliction? And in every one of those cases, it damages the respiration, forcing the cell into a fermentation metabolism, thus putting the cell on a path to dysregulated cell growth and cancer. So you can't get cancer if your mitochondria are healthy. You get cancer from any kind of a damage to the mitochondria in a population of cells in certain organs of the body. So breast cancer can arise from an occluded milk duct in someone's breast, leading to chronic inflammation, damage to the mitochondria in those populations of cells. Some other person may be exposed to a chemical carcinogen that damages the liver, therefore eliciting a liver tumor. Some people may have bladder cancer from chemical buildup. Some people get cancer from radiation. Some people get cancer from various viruses like hepatitis C, papillomavirus, HIV viruses. They get into the cell, they damage the respiration, then putting those populations of cells on the path to get cancer. So this is the paradox. And then some people inherit a mutation like the BRCA1, P53, or these kinds of things. People say, oh, that's a genetic. No, it's not, because there's a lot of people that have those mutations that never get cancer. They don't get cancer because that mutation in that person did not damage the respiration. Therefore, that person does not get cancer. If the mutation damages the respiration in the person and they get cancer, then that gene can be considered only as a secondary cause, because another person could have the same kind of cancer coming from an alternative cause. So they both can get the same kind of cancer, but in both cases, it's damage to the respiration, and the gene mutation and the chemical carcinogen are considered secondary, not primary causes.
And do these factors also weigh in on existing cancers? Does it make it worse, or could other factors influence?
Yeah, because you get if you can stop cancer before it spreads, obviously that's another issue. The metastasis is when the tumor then begins to spread, and I think many of these, anything that's not metastatic is considered benign. All right, so if you have a lump in a tissue or an organ, and that lump is pretty confined, you could possibly cure the disease by simply cutting out the lump. But what we have a tendency to do in the medical profession, which to me is a tragedy of considerable proportion, is we like to take a biopsy of the lump. So you take the lump, wherever it is in the lung and the breast or wherever, and you stick it with a needle, and you try to get cells from that so that you can classify what that lump actually is. So you give the tissue to the pathologist, and he looks at it and says, oh, this is benign, or oh, this could be malignant. The tragedy is that sticking the tumor with a needle can sometimes cause these cells that are on the verge of being metastatic to be metastatic. So you have like, you take, it's like sticking a beehive with a stick in the middle of the day. All the bees are going to come out. So you don't do that. You don't stick lumps to find out what level of people say, well, we have to do that. No, you don't have to do that. You put the patient on a metabolic therapy and you shrink the lump up really, really small, and then they have the surgeon come in and completely excise it if the lump is still there. You don't stick the lump to make a biopsy. And I can't tell you that this is a standard procedure. Sticking lumps for biopsies is done in most of the major hospitals, and it should be abandoned, because that's provocative and could put that person at risk for having metastatic cancer when they really didn't have it.
Okay, so one of the approaches we just talked about is the metabolic approach to fighting off cancer. Are there any other researches that are going on pertaining to fighting cancer these days that you're aware of?
You mean using metabolic approaches?
In conjunction with it, or is this just a very standalone sort of procedure?
Well, right now there's always when we have a new technology, there's always a hybrid transition period where the new technology could be used together with existing technologies, in the so-called hybrid approach. Eventually, it's realized that the old technology is holding back the new technology, and that they move forward with a purely metabolic approach once it becomes clear that it's the metabolic approach that's having the greatest therapeutic impact. And you can see the same thing with. I sometimes use the analogy of the ships. At first they were sail ships. Everything had a sail. Then, of course, they had sails with steam engines, and eventually the sails went away, and you have diesel engines, and you have this whole transition. And that's basically what I think will happen eventually for the metabolic therapy, because right now it would be too economically disruptive to the entire field if we transitioned everything off to metabolic therapy. I mean, what are all these guys who do radiation therapy going to do? What are all these guys, using toxic chemo? What are they going to do if you tell them that this is no longer necessary? There's going to be a transition period. So I think that, in our view, some of these chemotherapies use metabolic therapy. And people are somewhat comfortable with that. But, from our own view, we think it's holding back the full power of metabolic therapy. But it's too shocking to tell people you don't need to have chemo and radiation, to manage your cancer. Oh, I can't. People say, I can't believe that. Nor can most of the people at the top medical schools believe that.
Okay. So let's say if I'm a cancer researcher and we have the metabolic theory, I'm just a researcher in general. And considering that the Otto Warburg theory was devised quite a while back, it's not the newest thing on Earth, or is it? I mean, correct me if I'm wrong. So how do I sift through science in general? You've written a pretty kick-ass book that I've been plugging everywhere, Cancer as a Metabolic Disease. So what do you do as a researcher when it comes to...
Well, I mean, then you're up against the dogmatic, indoctrinated view of what cancer is. And for the last 50 or 70 years, 50, probably more than 50, maybe 60 years, people, since Watson and Crick's discovery of the DNA, which was in 1953, so right after that became the stampede to the genetic theory, and people just abandoned most of the biochemistry and things like this. There were a few holdouts like Pete Peterson at Johns Hopkins, but most people ran off thinking that cancer was a genetic disease. And pretty much, cast aside what Warburg had been saying. And there's also several problems with Otto Warburg in the sense that he had it right. His theory is completely right, except that he wasn't able to account for why some cancer cells took in more oxygen and appeared to be respiring when they shouldn't be. And, we have since elucidated this missing part of the Warburg puzzle. They can get energy from the mitochondria without oxidative phosphorylation through a fermentation metabolism inside the mitochondria. And that's completely, for the most part, not understood by the majority of people in the field. Because they're locked into a dogmatic view of what cancer is. And if you have large NIH grants looking for P53 mutations or sequencing cancer genomes and doing all this kind of stuff, you have a tendency to think you're doing something good and right. And it's hard to believe that most of the stuff you're doing makes no sense and it's nonsense. And that's a very difficult pill to swallow. And when you have the NIH and the major pharmaceutical companies, which are directing the kinds of research at the top medical schools, to say that this is not a genetic disease, it's a metabolic disease, you're dealing against a mindset that is very difficult to overturn. So it's an indoctrination, dogmatic view, and people just simply cannot believe that this is not a genetic disease because they've been indoctrinated, any more so than a person of one religion would come to the realization that his religion is not the right one and he has to go to another religion. Dogmatic view is an extremely powerful. As I said, I've never seen a gene as powerful as a dogmatic view of the mind, and it's so hard to change people's opinion, especially if their paycheck depends upon them not accepting the alternative view. So the problem is that this would be all well and good if this were purely an academic discussion. But the problem is we have 1,600 people a day dying in this country from cancer. And those people are being sacrificed needlessly because of a dogmatic view on a misunderstanding of what the disease is. So it's not an insignificant problem.
Yeah. So if I'm a student, what can I do in this sort of dogmatic environment? What are my options? And especially, let's expand it out. What about if I'm a practitioner? What can I even do here?
Well, it depends on and that's another thing that many of the oncologists that I speak to understand what I'm saying. They would love to be able to do metabolic therapy, but they can't because of the AMA's adherence to standards of care. You must use a certain dosage of chemo. You must use radiation. You must follow this prescribed procedure. Otherwise, you're going to lose your license. So, I mean, this is a powerful inhibition to people being capable of experimenting. Well, maybe somebody will say, well, I'll give them a ketogenic diet, but only after I've irradiated and used high-dose steroids, high-dose chemo. Well, that's nonsense. You have to realize, let's put it this way. What is chemo? Why are we treating patients with cancer with toxic drugs? And the answer is we want to stop the cancer cells from proliferating. I mean, this is why you're using chemo. So what are you doing? You're trying to stop these cells from proliferating. Okay, great. Why are we doing radiation? Because radiation will break apart the DNA and stop the cells from proliferating. And this is the reason why we use radiation and chemo, or the new immunotherapies, the checkpoint inhibitors and the CAR-T, immunotherapy, hybridizations, this T cell thing, which I know about. And then you say, well, what are the cells using to grow so fast? And the answer is they use fermentation metabolism with glucose and glutamine as the fuels. What happens if I take away glucose and glutamine? What happens? The tumor cells die. And you can do this without harming the rest of the body? Yes. Well, why is no one doing this? It's just like what they can't believe that the tumor cells grow on fermentable fuels, and if you take away the fermentable fuels, they'll die. Like, for example, diffuse B-cell lymphoma, which they're using for the CAR-T. So I call CAR-T as a Rube Goldberg. Rube Goldberg designed these very complicated ways of doing something very simple. Okay, you go on the web, you see a Rube Goldberg. So what are you doing to a patient? You take him, his cells are growing, his diffuse B-cell lymphoma, which is a very difficult disease. So you say, well, we have to take his T cells out, genetically engineer them, send them to California, bring them back to Boston, and inject them. This is nuts. What are you doing that for? All you have to do is take away the glucose and glutamine. You get the same result. Don't hurt the patient, and don't put him at risk. And it doesn't cost you very much money, right? It's a no-brainer. It's a no-brainer. And yet they do this because they think cancer is a genetic disease. That's the way you have to deal with it. And I'm saying to myself, don't these people read the literature? Don't they know anything about the biology of the disease? So it's kind of it's all because of the lock-in dogma. So it's an extremely difficult thing to break. But I think once people come to realize what I'm saying, I mean, the whole field has to change because we can't do what we're doing. It doesn't work. It's too expensive and it doesn't work. So, I mean, It works for a few people and we hold them up as the poster child and say, oh, look at this one guy does really well. What about all the others that are dying?
Yeah. What's interesting, which I want to pry a little bit, is why glutamine? Why specifically that? Why not the others?
Well, glutamine is the most abundant amino acid in the body. And glutamine can be fermented in the mitochondria through the succinyl-CoA ligase step. People didn't realize this, but this is a very major source of energy. I've been talking about this. and telling people, but they just can't. They don't understand it. They don't believe it. I don't know what's wrong with them. But the bottom line, I wrote this in many papers, and people kind of ignore it. So it's a powerful fuel for generating energy, ATP, to keep those cells going. You also have to realize that it is the fermentation of the tumor cells that protects them against radiation and chemotherapy. So people say, oh, these cancer cells are tough. They always seem to find a way to survive. And that's because the availability of glucose and glutamine is always present in the microenvironment. And they prevent the cells from dying from reactive oxygen species. So our plan, which, reactive oxygen species is how radiation hits a little water and blows up the cancer cell by ROS, reactive oxygen species. But at the same time, you're damaging the normal cells in the body. Is there any way to increase reactive oxygen species only in the tumor cell and not in the normal cells? And that's why we shift everything over to ketogenic diets and we reduce the two fermentable fuels. You have to realize the fermentation acts as a shield against reactive oxygen species. So that's the reason why chemo and radiation will not be effective in killing all these tumor cells. So once you remove the fermentable fuels, they become prone to die from reactive oxygen. How do you do that? You put them in hyperbaric chambers. Therefore, you put the oxygen under pressure, it gets dissolved in the blood, and then blows these cancer cells up in a non-toxic way using the similar strategies that radiation and chemo would use without toxicity to the rest of the body. It's an elegant, simple procedure.
Are there any exceptions to the metabolic theory? I mean, or is it always just going to be applicable?
I think it'll be applicable for the vast majority, if not all, cancers in one way or the other. I mean, Warburg's, what we call the Warburg effect, is seen in almost all cancers. And in those cancers where it's not seen, they're burning glutamine like crazy. So the glutamine is being fermented through a different pathway than is the glucose. The glucose fermentation, lactic acid fermentation, takes place in the cytoplasm, whereas glutamine amino acid fermentation takes place in the mitochondria. Both of these are generating the ATP for that cell to grow. So you take away that. And the other thing is they can't use the ketones because they have defective respiration. So what we do is we bring the whole body over into a therapeutic ketotic state. So the first step in managing cancer is you bring the body into therapeutic ketosis. Once the body is in therapeutic ketosis, now you can begin to take away glucose and glutamine to the tumor cells because they can't adapt to the alternative fuel and they become marginalized and killed. So the whole thing is it's a stepwise procedure. You don't just give them a bunch of drugs and you got to work. In fact, we published this paper called the Press Pulse, which outlines very, very clearly for clinical trials exactly the strategy that we need to go through. The biggest problem right now is doses, timing, and scheduling. So we haven't yet worked out the perfect dose, the perfect timing, and scheduling for the different components of the Press Pulse procedure to completely eliminate the cancer. But this is not an insurmountable problem. This is just more or less trial and error and doing this. And as I said to people many times in these podcasts, it's not sexy science. This is not the kind of science that gets you big NIH grants. This is kind of a working man's view of a low tech kind of non-sexy way. But do you want to live? Well, what's the purpose here? Isn't you want to survive the disease? You don't want to know that, hey, I got scientists working on sexy things, but it's not going to save me. I want somebody doing something that's going to save me. And it's very hard to get people excited about very simple kinds of things.
Yeah, the only concern that I had was that let's say the whole population on Earth somehow magically becomes ketotic. Then are we going to create cancers that could potentially run on ketones and adapt to that?
Only if the mitochondria becomes very healthy. And that doesn't define a cancer. Cancer cells have defective mitochondria. So if everybody's in ketosis, they're all going to be very, very healthy. That's not going to be a problem. Now, can a cancer cell adapt to a very low glucose, very low glutamine environment and hang on? In other words, okay, we targeted the majority, but we can't get rid of all the cells. Is it possible that these guys could come back at us? And the answer is, of course. But we have ways to deal with that if we know there are a few survivors. And here's where, some of these checkpoint inhibitors or some of these very expensive, sophisticated, sexy kinds of things could come into play at the very end of the deal. In other words, they're the closers at the end. You could go after a marginal number of cells that all have a similar epitope on the surface, and therefore one of these immunotherapies could be it's like when you go to the dentist, the final thing is you get your teeth clean. It's like Okay, the immunotherapy might be the final step in eliminating the few cells that you have left in your body. But you don't go after the beast with an immunotherapy. It's not going to work most of the time. I mean, you're going to create all kinds of problems doing that.
So here's an interesting question. Since you're a super skeptic, it seems, let's say I'm a layman person. Most of the people that are listening to this podcast are laymen. They're not going to be super duper smart. So, I mean, they're smart, but not as intellectually, as in they don't have PhDs or they're not.
They don't have to.
Yeah.
What I'm telling you, you don't have to have a PhD to understand this.
Yeah.
Okay. So, and I find the lay people are oftentimes more astute to these kinds of things than are the so-called professionals in the field.
Okay.
The lay people are not indoctrinated. They have a very open mind. They look at things rationally.
Okay. So my question would be, let's say if it's just any medical procedure, doesn't have to be specifically cancer. How do I deduce that this is not just BS and it's actually something that will work?
You mean the metabolic therapy?
No, just in general, like a medical procedure. Like if I go to my practitioner or physician or anybody and they say, hey, I'm going to do these steps. Doesn't have to be specifically cancer. So how can you figure out a specific medical procedure? Doesn't have to be cancer, like I said. How do I gauge that? How do I figure it out?
If it works.
Okay.
I mean, for a hip replacement, for example, everybody's getting. I got a hip replacement. I put it off for years. I didn't want to get those guys. I thought they were going to kill me, But they've got the procedure down so perfect in the majority of cases that most people come out of these operations and they're far better off than they were before they went in. All right, so that's something that works. It's been documented. People are doing really well with some of these kinds of procedures. I mean, there are many other in the heart field. Cardiovascular section, it's in these multifactorial chronic diseases where we have failed miserably. Okay, type 2 diabetes, cancer, some of these Alzheimer's disease, these kinds of diseases that are related to chronic situations associated with diets and lifestyles. And we have a powerful food industry that's against this. The sugar industry doesn't want it. Are you kidding me? You think half of this stuff is like you're turning the whole cart of apples over here on this thing, rather than ketogenic diets work great for managing type 2 diabetes. I mean, there's a lot of evidence to show that this works. I mean, and yet they deny it. It works great for cancer, but not as a standalone therapy. It's not for cancer. You can't cure, in my mind. I don't think you can cure cancer. People say, oh, Seyfried says you can cure cancer with a ketogen. I didn't say that. I'm telling you I didn't say that. Is it important for the eventual successful management of the disease? Yes. Will it stand alone as the cure for most? No, I don't think so. Because you're not targeting you're not handling all the players. So those procedures in medicine that have been vetted and shown to be really, really successful, I think you have confidence in that. It's just when you get into these areas where people have a different idea about what the origin of the problem is, then you have all this, like we have the cancer industry. It's upside down. I mean, it's a tragedy. I mean, right now, that's a miserably failed. And then people say, well, you can't say it's all failure because we have so many so-called cancer survivors. How do you account for all these cancer survivors? Listen, most of those cancer survivors, many of them, not all of them, have all kinds of new diseases that they got from being treated with toxic poisons and radiation. They now become new patients for a new field of cancer survivor medicine. So they have depression, cardiovascular disease, hormonal imbalances. They have all these things they never had, but for the fact they were treated for cancer. This is crazy. What are they having all these problems for? Well, they're being poisoned. Well, if I took a whole bunch of people that didn't have cancer and poisoned and irradiated them, they'd have all kinds of problems too. So the whole thing is like, can you manage the disease without causing toxicity? And of course, at a reasonable cost. Oh, you don't want to hear about that. Can you can do this on the cheap? And the answer is yeah. Well, relative to some of these other things. Well, that's another disturbing factor.
Okay, so I'm curious about the history of cancer, basically in general. Now, this is a bit of a broad question, but what's been going on? Has it increased in this last 100 years or 200 years? Has cancer been so prominent in human history, or is it just a modern disease?
Well, I think that's it's all related to the amounts of carbohydrates and nutritionally depleted foods that we have in our food chain. I mean, let's be honest. I mean, there are unintended consequences of advanced technologies, and one of them happens to be cancer. Okay, so we have all kinds of greater numbers and kinds of pollutants in the environment. We have foods that put us at tremendous risk for creating the inflammatory situation in our bodies that would precipitate a cancer. Now, we're not going to go back and live in caves, all right? We know this, all right? We're not going to go back and eat nuts and twigs and, kill squirrels in the backyard because they're healthier. We're not going to do that. But as long as we know what we need to do to keep our mitochondria healthy, at least that gives us some level of control over the situation, rather than saying, "Oh, cancer is inevitable. We're all going to die from cancer." No, you're not. You just put yourself in a position where that's true, but not if you know what to do. So if people were therapeutically fast for a few days, during the week or whatever, you can significantly reduce your risk. We're eating carbohydrates, massive amounts. We're not exercising as much as we should. We're putting ourselves at risk for all these different kinds of diseases. And, the more technology we get, the less we have to move ourselves. You can almost control everything in your house sitting on the couch. It's like you don't have to get off your ass to do anything. So, and that puts you at risk for systemic inflammation and the risk for cancer and Alzheimer's and some of these other chronic diseases.
And so this brings me to a good question, which is, can you see these red flags in the horizon that are predictors of cancers, or is it just going to hit you?
No, I think in some cases it just hits you, and for reasons which may have been simmering for decades, and you just can't know that. Like some childhood cancers, some of these things were developmental anomalies that just happened to put a population of cells in a hypoxic environment. People, we know if you're exposed to tetrahydrochloride and cigarette smoke, and you put yourself at tremendous risk for certain types of cancers. You're exposed to hepatitis C or papillomaviruses, you put yourself at risk for getting those kinds of cancers. So I think you need to know what the risk factors are and try to avoid them. And if you can't avoid them completely, then at least you know what you need to do to try to bring your body back into a more metabolically homeostatic state, which will then delay. I'm not going to say it's going to ever. It could delay or reduce the risk for getting the disease. So there are things that they just have to know about it. If you know that cancer starts in your mitochondria, and that's the origin of the majority of, if not all, cancers, then how do you protect your mitochondria from those kinds of damages? Exercise, moving around, eating low carbohydrate foods, bringing yourself into a level of therapeutic ketosis. These are things that people can do. Now, is it comfortable to do that? No. I'm not going to say go out, listen, I can't wait to get into therapeutic ketosis. Are you kidding me? Some guys would rather die than go into therapeutic ketosis. I mean, the guys will always say, what do I have to do? I says, don't eat for a week. Well, I'll let somebody else try that. I'm not going to do that. It's human nature. And I don't care what nationality, what religion. I don't care. You go to Japan, China, India, and you tell people that they have to get off the rice and off the pasta or whatever it is. Hey, I'm not doing that. That's part of my culture. I got to have rice every day. No, you got to stop eating the rice. Oh, no, I can't do that. So you're up against, but once people become educated and understand that they don't have to be off rice or pasta or bread all the time, they just have to periodically get off it so they get themselves into therapeutic ketosis. And they know the longer they stay in the therapeutic ketosis, the healthier their mitochondria begin and the less risk they're going to have to developing cancer. So you take people that are all have obesity and they have inflammation, C-reactive protein. That's another thing. Every time you go to the doctor, ask them, what's my CRP, C-reactive protein? It's a very important measure. It tells you what your level of systemic inflammation is. If your CRP is too high, you're at risk for cancer. That's going to damage your respiration and put you at risk. So you got to know to reduce that. So when you go, every time the guy goes to the physical, always the first thing, what's my glucose, ketone, and what's my CRP? Of course, ketones, if you're not in therapeutic ketosis, it's going to be very hard to measure that at all. But that's why the meter the GKI, will allow people to put themselves in therapeutic ketosis. This will reduce their risk for all kinds of things.
Okay. So what does it mean by a healthy mitochondria?
It's a mitochondria that doesn't produce reactive oxygen species, okay? And there's a certain part of the electron transport chain in the mitochondria that has a propensity to produce reactive oxygen species. It's part of our natural metabolism, okay? ROS, our reactive oxygen species, they increase entropy. Entropy is the second law of thermodynamics, which is disorder. We all die from entropy. We all reach equilibrium. We don't exist anymore. So the bottom line is we're all going to die. We all die because our mitochondria become damaged slowly and surely over all these years. None of us are going to live forever. But the issue is you can delay the inevitable by keeping your mitochondria healthy. And if you keep your mitochondria healthy, you delay a lot of things, not only cancer. You delay heart disease, you delay, cardiovascular, obesity or these other dietary related conditions, and perhaps even Alzheimer's disease, which we're learning about now as a type of disordered energy metabolism. So the whole thing is just, how do you delay entropy by keeping your mitochondria healthy, producing less reactive oxygen species, which comes from burning ketones. When you're burning ketones instead of glucose, your mitochondria will produce less reactive oxygen species and delay entropy, which is the second law of thermodynamics and ultimately disorder for your body.
Are there some cancers that are still giving us a lot of trouble these days?
Well, the ones that are highly metastatic, of course. I mean, these are the ones that spread your body before you even know it, like pancreatic cancer. Glioblastoma is a real tough one, which is the one we work on. We work on a lot of GBM. But, we work with our colleagues in Turkey. We work on pancreatic, lung cancers, all the heavy hitters, advanced metastatic lung, pancreas, ovarian cancer, triple negative breast cancer, these kinds of things. So, those cells are already disseminated through organs and throughout your body. So you become a non-candidate for a lot of these kinds of things. And then you're treated with these very toxic drugs, which put you at risk for all kinds of other health maladies. And when you have highly metastatic cancer, it's just, you shouldn't be using all this toxicity. We can kill those cells by taking away glucose and glutamine. And that's still we're still in the developmental stage on that right now. But we've seen it work, and it works remarkably well if you can do it the right way.
Are there specific biomarkers that you're going to see go off the chart when there's cancer in your body?
Yeah, there's a number of different markers that people use for various kinds of cancers that they use as, you have these markers in your blood that are indicative of a like the PSA test, or you have these other CA markers, cancer markers in your blood, and people use them as kind of a biomarker to see whether or not. So we put people on therapeutic ketosis, and many of those cancer biomarkers disappear. So right off the bat that something's working. But the question is, how do you combine that with the appropriate drug cocktail and procedures to fully eliminate the tumor cells? And you can use these biomarkers as an assessment of what's happening. We can do that in our preclinical models because we've genetically engineered the tumor cells to give off light. So we can use light, and we use quantitative polymerase chain reaction molecular procedures to detect even down to the single kinds of numbers of cancer cells. So we know if we're successful, we have the light goes out and we have no way to detect any surviving cancer cells. And to be honest with you, we have never achieved that total success yet in our preclinical systems. So we're coming close, but we have not achieved success. I don't want to make people think that, that we can cure every kind of a cancer. All I can say is that we're on the path. We're on the correct path. We know what we need to do. We just have to perfect it and streamline it. And I think we'll have the kind of success that will work for the majority of people. And the thing that we're shocked about is that the humans who actually go out and try this, do a hell of a lot better than our mouse models. We have the real natural models of cancer in the mice. Most people who study cancer in mice, they use these artificially genetically constructed kinds of models. They're artificial, and they give you artificial information. So people say, we cure cancer in mice all the time. You don't cure. You get a mouse that has a glioblastoma, you're not going to cure him any more than you're going to cure the human. So, but most of these mouse models are artificial. So it gives the lay public a saying, oh, these guys are curing cancer in mice all the time. Well, it never works in humans. No, they're using the wrong mice. You use the right kind of mouse, it's much more difficult. But we're getting good results in dogs. So the canine community is coming around to recognize the power of metabolic therapy. And we've had some tremendous success in eliminating and resolving cancer in a number of different dogs that have advanced cancer using metabolic approaches. So some veterinarians are very excited about this. The vet food industry is not excited about this because the same problem with the, dogs shouldn't be eating grain. Let's be honest. Grain increases the inflammation in the dog's body, and they get entropy, and they die from cancer and all these other things. So, the whole thing comes back to putting our species, humans, mouse, on a more natural kinds of diets. And then you enhance metabolic efficiency, and you prevent these diseases, or you can actually manage them too.
Okay. So let's say my oncologist comes up to me and tells me, okay, you've got some cancer. How should I start this discussion, and what kind of questions should I ask that person?
Well, once you say, first of all, let's hope he can do it with what we call non-invasive procedure. Let's hope that they can use MRI or PET scan or something that's not going to disturb the beast. All right, you got a lump, you got some sort of a disturbance in the gut. You might have some bleeding, you might have some whatever. There's a lot of ways that these tumor cells can present themselves. Different places can present with different. You start peeing blood. There's all kinds of things. Okay, great. They do a non-invasive procedure. Now you go on metabolic therapy. So now it's in your hands. You just tell the doctor, listen, I'm going to do metabolic therapy for a few weeks, and then I'm going to come back and have you look at me again. But they'll say, oh, no, you got to have the surgery right away. No, you don't. Unless you're dying, you're not going to. Most of these people who come into the guy, they look healthy. Oh, I didn't know I had cancer in the first place, right? He goes in, starts cutting you up, and starts poisoning you, and you look terrible after a few months, right? He's giving you toxic poisons. You don't need that. I'm not saying we don't do that. I'm just saying there's a time and a place to do that. And right up at front is not the time or the place. So you can manage. I've seen people come in with horrific colon polyps or uterine polyps, go on metabolic therapy and resolve it so they don't even have to have any surgical procedures done. Now, I'm not going to say that happens to every cancer, but in brain cancer, we did one with a GBM. We have it under publication right now. We took this guy and we put him on a metabolic therapy for several weeks before we debulked the tumor. And then when you debulk the tumor, all the blood vessels come back in. It's like all the bees come back into the hive. And then you pluck the hive out when all the bees are in there, and you're going to have much, much greater success. It's unbelievable. It's unbelievable. You don't go into this guy and start mucking around in his brain right off the bat. What are you going to do? The bees go out, and the poor guy's going to be at a disadvantage to survive. You do that with all the different cancers, pancreatic cancer. Put these people on metabolic therapy, then go in and reassess the situation. Everything is backwards. We're not doing it the right way and putting all these poor people at risk for metastatic cancer and death. It's just terrible.
Okay, here's a general sort of question. How do I know I'm not thinking in a dogmatic way?
About what? Metabolic therapy?
About science or research or in general. I'm just thinking in the perspective, since a lot of people who listen to our podcast are youngsters who are coming up, and so they would want to know, hey, how do I know I'm doing the right thing?
Well, that's a good point, because if you go to the hospital and everybody says don't do that, then you're really put into this conundrum. Oh, this guy from Boston College said I should do this or that or consider this or that. Completely different than what the so-called expert. Well, then why are we having 1,600 people a day dying if these guys are so expert? And all these other people that do survive have all these metabolic maladies. The issue is, can you move beyond what is the way to deal with this disease based on what we know about the biology of the problem? So then you have to say, well, cancer is a genetic disease, and that's the way it is, and you have to realize that. And maybe it's not that way. So where's the truth? So you're asking the question of, where does the truth come in, and where does your capability of weighing the information in a logical, objective way that makes you come to the realization that this is my path and I'm going to take this path, even though the guy at Dana-Farber, MD Anderson, says I shouldn't do that. So now you have to say, okay, who's telling me the truth? What makes the most sense? What has the most support from the science that has been done. Okay, so there you're coming back to what is the truth and the nature of the disease. And if you're telling people, say, well, I have to radiate and poison because it's a genetic disease, this guy doesn't know what the hell he's talking about. So it's very clear. So he does that because he's been trained to do that. He doesn't understand the biology of the disease. If he did, he wouldn't be doing that. So when you see people with a bald head, why do some cancer patients have a bald head? Well, their hair falls out. Why did the hair fall out? Well, he was given a drug that stopped cell proliferation and the hair follicles fell out. Well, why don't you just take away glucose and glutamine? You'd kill the tumor cell and his hair wouldn't fall out. Oh, I didn't know I could do that. It's just like, well, if that were so true, I would have learned about it in medical school. Wrong. You would not learn that in medical school because the medical school curricula is written by the pharmaceutical companies. You got to, in part, not all the time, but you got to realize, what's going on here. People have to stand up and say, what is going on here? We have 1,600 people a day dying from cancer, and it's a silent epidemic. Nobody seems to be concerned about it. Oh, that's just the way things are. No, they don't have to be that way. They don't have to be that way. Everybody thinks this is the way it is. So people have to come to use their own mind about this.
Are you passionate about the groundbreaking and heroic research of Dr. Thomas Seyfried on metabolic therapy and cancer? So are we. That's why we've created something special for you, in collaboration with Johnny Rockermeyer, a German book publisher and translator. Introducing our collection of meticulously crafted books that distill the essence of Dr. Seyfried's work. Dive into the science and discoveries. These summary books are your gateway to understanding the intricate world of metabolic ketogenic therapy in a clear, concise, and engaging way. Whether you're new to the subject or a seasoned enthusiast, our books offer insights that can change your life. Ready to explore this transformative knowledge? Visit our website at www.cancerasametabolicdisease.com to get your copy. You can buy the ebook there directly and the paper book via the provided links. Here's the best part. A portion of every purchase goes directly to support Dr. Thomas Seyfried's groundbreaking research. That's why the direct ebook purchase is the best option to donate as much as possible. You can see all of the donations Mr. Rockermeyer has already made at www.ketoforcancer.net. That's right, when you buy our books, you're not just investing in your own knowledge, you're also contributing to the future of cancer research. Help us make a difference. Together, we can drive change and save lives.
So how can these educational institutions change then? I mean, you're part of one. What can they do? Or are they just so limited that there is no hope?
What I think is happening is there's no outrage. There's no demand. There's no people. Yeah, they'll all say to me, oh, well, I know the pharmaceutical companies are making a killing on this. Well, what are you going to do about it? No, I'm not going to do anything about it. Yeah, I know cancer is just a fact of life. We're all going to die from it because everybody tells me that. Oh, okay. Well, then go sit and eat the bonbons on the couch and watch the TV and don't do anything. I mean, there's no outrage. There's no social outrage about what's going on here. And then at night, you see these television commercials and you hear every year, we got a new breakthrough. We're going to cure cancer, but a big breakthrough. That's all smoke and mirrors. It's also to go back and look at the number of dead people year in and year out from this disease, from all the breakthroughs that we've had over the last 50 years, the silver bullets, all of these new immunotherapy, all this kind of stuff. And then you find out one of my students is doing a new project that's called another form of cancer toxicity. It's called financial toxicity. So if you don't die from the adverse effects of the toxic drugs, you go bankrupt trying to pay for the disease, and you get anxiety, and the cancer comes back, and you die that way. I mean, this is horrific. And nobody seems to care. I mean, it's like I've been telling people this, and everybody says, yeah, we knew that. Okay, then great. Then go down and get irradiated and poisoned to take care of your cancer. I mean, it's just like, what are you supposed to say? I mean, here's the data. Here's the evidence. Here's the people that are doing well. And I can't believe it because the guy at Dana-Farber says it can't be that way. Well, what do they know? Half their patients are dying down there. I mean, it's like, or their hairs are falling out. They're coming back. They get all these. They opened up a new form of medicine down there called cancer survivor medicine. Depression, cardiovascular disease, all these kinds of horrific things that are happening because you've been treated with all these crazy things, trying to stop the proliferation of the tumor cell, which is surviving on glucose and glutamine. So you bring it all back to the biochemistry, and it becomes very clear.
And this becomes a very, very scary thing at the same time, that these people who you have put prefixes behind their names and they went to medical school, and now comes a layman person who knows a little bit about the metabolic theory, that may be far more effective than the guy who's got the, years and years of training. So are we in a health crisis right now?
I think in cancer we are. I think in that situation we are. The fact the lay people, my students in my class know more about cancer than most of the people that are in the practice. These oncologists never heard of metabolic therapy. Are you kidding me? They never knew that the mitochondria was dysfunctional in cancer. Are you kidding me? Don't they read the literature? Don't they understand the basic biology of the disease? It's like, give me a break. The people that are actually they know how to give you the correct dose of radiation without killing you. They know how to put yourself into a high dose chemo without killing you. So this is what they've been trained to do. Now, they're not being trained. Many of these folks they're good people. They've just never been exposed to the information that I'm telling you. They don't get it. Where are they getting this? They get it. They indoctrinate. You go from the time you're high school, college, medical school, cancer is a genetic disease. Cancer is a genetic disease. Cancer is a genetic disease. And then you go and you get trained to use chemicals and radiation to kill the proliferating cells because they're genetically programmed to grow fast. So the whole thing is a dogmatic view, and your approaches are all based on the dogmatic view. So now you're coming along saying, hey, stand back, man. This is a totally different kind of disease than what we thought. Well, if I would have had that in medical school, are you kidding me? What are you going to be telling? You're going to use food as medicine? You're going to use low-dose chemo? You're going to use things that are totally in a different perspective? You have to be retrained. So what's happening is the patients, the cancer people, through your kinds of programs and others, are becoming aware of what's going on. And they go to the hospital and say, I'd like to have metabolic therapy. And the poor physician doesn't know what to say. So the patient says, I want to be treated with metabolic therapy. And the guy says, well, I don't know about that. Okay, great. I'm going to go somewhere where they do know about that. And I've had physicians calling me and say, hey, can you help me? I want to do metabolic therapy, but I don't know how to do it. So they have to then go and find people that know how to do this, because it's not simple either. If you don't do metabolic therapy the right way, you can hurt people or not help them. Okay, so you need to have people that actually understand about therapeutic ketosis and certain zones that you have to be in before you go sit in a hyperbaric chamber. You have to have people that are trained to know these particular things. This is not like, simple. It's just a retraining, understanding what the nature of the disease is, and then using the rational approaches to manage the disease.
Awesome. So this is an interesting community question that I got emailed or sent on our social media, which was, what advice do you have for people post-cancer? Are there specific precautions they need to take? Do they need to have a glucose index between 1 and 2, or what?
Well, I think, if you've survived cancer now and you're on the, because a lot of these things will recur at some point in the future. Sometimes they don't. But I think people who understand that a recurrence could involve further damage to mitochondria in a population of cells, I think they would use the same strategy that you would use if you never had cancer in the first place. You just try to keep your body as healthy as you can. You know what the precipitating factors are that will elicit a new tumor. You can't be 100% sure because, the chemicals and radiation that people are used can damage the respiration in certain populations of cells, putting those cells now at risk for a recurring tumor, either in the same spot or in a totally different spot of the body. So we have to be aware of that. And as long as we're aware of what precipitates the disease, we just simply try to avoid that or do the best we can to minimize those provocative situations that would elicit a growth of a tumor cell.
Okay. And what about these auxiliary food items that people like to consume occasionally, such as coffee and alcohol?
Well, again, I'm not sure about coffee. Alcohol is certainly an issue. It's hard to say because sometimes alcohol is also dovetailed with smoking or some other kinds of activities that are compounding risk factors. So, what we found in our studies, certain drinks like dark red wine, people who were in therapeutic ketosis who consumed like a Cabernet or a Burgundy or one of these dark red wines, these did not throw the individuals out of ketosis. So people don't have to feel they have to go on this draconian kind of existence where I can't never drink another drop of wine in my life. We also found that very expensive champagne, Small bubble, so-called expensive dry champagnes don't throw you out of ketosis. But bourbon does, and beer does, and some white wines do, some of these kinds of things. We haven't tested every kind of an alcoholic beverage in therapeutic ketosis, but we know certain ones that don't throw you out of ketosis. So I think it's not, and people now with the new diets and the new approaches are giving meals and plans that are actually not so bad. And a lot of people can live in these zones and feel that I'm still part of the society, rather than having to sit in a room by myself and eat lard out of a can. It's like, we're moving forward in our understanding of diets and procedures and lifestyles that will keep people in therapeutic ketosis and still have them participate in what we do as a species, which is a social interaction. So there are a lot of ways to do this. This is a very rapidly emerging field. A lot of people are using ketosis for weight loss. I mean, they're using it for all kinds of other things. For, extreme athletes are using this stuff. Our focus is primarily on how do we prevent cancer, and if you have cancer, how do we kill it? And this is our strategy. This is where we put our focus. I'm not into weight loss. I'm not into these other kinds of things that a lot of people are excited about. Cognitive improvement. Some people say, "Oh, if I get into therapy, I'm so cognitive." Well, that's well and great. And that's another possible, thing that's associated with therapeutic ketosis. But it's hard to quantitate that. It's very easy to see a dead tumor cell in a histological preparation, and that's what I like to see. I like to see dead tumor cells, and when I see dead tumor cells, I get very excited.
That's a fun way to kind of put it. So what kind of books would you recommend for layman people, practitioners, or students?
Well, I think for a general understanding of the cancer fiasco, Travis's Tripping Over the Truth, the emergence of the meta, that was written based on my book, but it was more for the layperson. I think Miriam Kalamian has written an exceptionally good book called Keto for Cancer. That's another book that's just come out recently. Ellen Davis has put together some nice keto recipes. Patricia Daly out of Ireland has put together some nice information on her on her books. So I think there's more and more people coming to the awareness of how to go about doing this and are taking a general interest in it. Not only if they have cancer, but also in prevention and just general health view. And then, of course, if those guys that are really into it, they go out and get the glucose ketone meter from Abbott Labs, or you can get it on Amazon. I think they're only $35 each. And then and there's a new company coming out called Keto Mojo, and that's another ketone meter that measures both glucose and ketones. And people can get into this, Heads Up Health. There's a lot of ways now you can take charge of your own body, and I think that's an emerging field that'll significantly reduce cancer risk.
All right, fantastic. So, is there any topic that you'd like to discuss over here that we might have missed out on?
No, I don't think so. I think I pretty much touched, unless you can find something. I discuss a lot of these issues, and it's an emerging field. We always learn new things each time. We learn them from the cancer patients. We learn them from people who are just doing therapeutic fasting, and they feed us back information. And it's good that people are going to try to take charge of their health. And I think it's going to even be better when the physician and their health provider is also in tune with the same concept, so that the patient and the physician will both work together as a team to improve the health of the individual, rather than the physicians and the health providers acting as adversaries. Because I feel bad. A lot of the physicians, they get they become dismissive of these things because they never heard about it, and they feel that they like to be in charge and direct the patient to do this or do that, and they get a little bit taken aback when the patient seems to know more about this than they do, and so it only becomes a gradual education where the physicians are actually trained in this, and they can be facilitators of these kinds of therapies. And hopefully we're going to move in that direction in the future.
Where can these physicians or practitioners or nurses, where can they go as far as conferences or events are concerned? Are there any specific ones?
Well, Dominic D'Agostino ran a couple of years there with the Prove It company, because a lot of companies are getting involved with this. And people ask me all the time, I got this new ketone solution that somebody's talking about. Is this going to help me? And I said, I don't know. Measure your GKI and see what it says. If the ketone supplements are really putting you in therapeutic ketosis, then your GKI value will tell you right away. If it's not, then don't take that. It's like so. The organizations that the American College of Nutrition is now getting involved with this in a big way. A very old and distinguished branch of nutrition. More and more. It's still, if you go to the American Association of Cancer Research, you feel very little about this. This is more, these guys are all gene guys. They're all pounding, sequencing DNA and all this. They're not into this. And if you go to the big pharmaceutical meetings on cancer, the ASCO meeting, they're all into heavy drugs and radiation and all this kind of stuff. So it's more or less coming from the grassroots. It's not coming from the top. The people are hearing about this through the media, like your program and other programs, and they're beginning to ask questions. And those questions are now impacting on the medical community, and they have to know answers. So the wise layperson will know right off the bat whether such and such a person is really on top of this whole thing. If you go into the oncologist and he says, I never heard of this, go find another oncologist that has, because this guy's out to lunch. So these guys got to get on the ball and figure out what they're going to do to help their patients. Otherwise, these patients are going to go somewhere else. And there's going to be a few guys that know about this, and they're going to be overwhelmed with the need to service all these people.
All right, fantastic. I think that's about it. Do you have any message for anybody out there?
No, I think the word will get out slowly but surely. Bottom line is, people want to live. They want to stay healthy. They want to know about what they can do. They don't want to entrust their soul to an organization that may not have the best track record. So having this information arms and gives knowledge to the public. And believe me, when you say lay people, these lay people are sharp. They actually look and they read and they discuss, and they have different organizations where they can discuss and ferret out all these different things. And then they can come back to me or others and ask specific questions. And our job is to allay their concerns or address their issues. And only in that way will they become more and more. And we're publishing case reports one after another, showing how this stuff actually works and people that are doing really well. And I think as these reports become more and more prevalent, more and more people are going to want to know about this.
Okay. And what can people expect from your book when they open it up?
Well, it's a book. It's some chapters any layperson can read and appreciate. Other chapters are made for those guys that are really deep into the biochemistry of cancer. So there are going to be some chapters that are easily readable and other chapters that are going to be struggling through. And I know that because even some of the guys in the field struggle through it. But I, it was a book that is heavy into science, but not completely into science. It's into practice. It's into the evidence. I tried to write it in as clear as I could. I have to be honest with you. Chapter 4 is a struggle. It took me, several months to write that one chapter anyway. But that's only for the heavyweights that are really deep into this, into the actual biochemistry. But there are other chapters that, a cancer patient could read. The whole section, chapter 19 on prevention. Then there's chapter 20 on the case reports that people have reported back. So, chapter 1 is pretty much what the hell cancer is in the first place. All the different definitions and all the different aspects of this. So it goes through the Warburg controversy. Why did Warburg get thrown out? Why did they dump him when he actually had the keys to the kingdom? What's going on here? Why was he this? So this is more of a kind of a story based on the politics of the situation. So some chapters are going to be very easy to read. Other chapters you can skip over those unless you're big into biochemistry. So some people say, I have to stop reading this. It's too complicated. Go on to the next chapter. It's not as complicated.
That was my excuse. It's like everybody was telling me. I think if you go on Amazon right now, you see Dr. Dominic's review on it right on top. And everybody's like, this is a bit of a difficult book. So I'm just making sure that if a person like me could totally understand, because I really, really want to buy that book. Because it seems like that's the one, your book, I don't know if you want to give credit to it, but I want to give credit to it. it's done a lot. It's changed a lot of ways how people think.
Yeah, well, it's it has, and I'm shocked because the sales of the book are actually going up after all these years, which is kind of surprising. It's doing better now than it did when I first wrote it. So, but it's not cheap. It wasn't made for the lay person. It wasn't one of these Signet Classics or something like this. It's a heavy book, but it's also light.
Okay. So just as a final plug, when can people reach out to you, and why should people reach out to you, and how can people reach out to you?
Well, I'm not a physician. I don't treat patients. I work with clinicians and oncologists that do treat patients. I do the best I can at directing them in the right direction, getting in contact with people that can actually prescribe medication and do this. All I can do is enlighten them on what the story is and understanding. But, I'm a professor in biology department at Boston College. I don't have a license to practice medicine. I don't practice medicine. I just tell people who they should go to and what they should do to enlighten themselves, and then talk to others. And that's all I can do right now. And some of my friends who do that are actually getting overwhelmed. They're just like buried with patients who want this information. And it's a shame because they should be getting this from their local oncology groups, and they're not.
What can we do as podcasters? And technically we're food companies at the same time. We have keto-friendly stuff. But what can, as a voice for people, is there something we can do?
Well, I think you're doing it. You're putting out the word. So, and then, of course, there are organizations. And one last thing. People, unfortunately, we have fragmented the cancer field. And I think this is a real problem. And I think that you have organizations of brain cancer. You have the blue ribbon breast cancer things. You have bladder cancer, lung cancer groups. Every cancer thinks they're a separate disease. And they all fund, like, I'm going to fund money for lung cancer or brain cancer or breast cancer or something like this. This is a mistake. All of these cancers are exactly the same disease. It's time that I call it the tribes need to unite. Somebody has to unite the tribes, because people think breast cancer is different than brain, different from lung, different from bladder, different from colon, different from all the different organs. They're all the same. All the tumor cells ferment glucose and glutamine, no matter where the origin of the cellular. So we should organize the tribes and bring them all together in one great, we have cancer. It's the same disease. What are we going to do about it? So in this way, we then consolidate the people that are really interested in making a change. Because right now, the organization is fragmented. People are raising money for these different cancers, and we're fragmenting the power of what the people have to say about this. I'm telling everybody it's one disease, not 100 diseases. And when you go to the genetic guys, they're saying cancer's 1,000 different diseases because they have 1,000 different mutations. It's not, the mutations are irrelevant. The mutations are irrelevant to the nature of this disease. It's a fermenting disease. Get the tribes together. Make sure they know about that. Your organization can help doing that. Tell everybody that it's the same disease.
And Professor, just want to let you know that after listening to Dom's podcast on Tim Ferriss, which probably created a lot of other businesses too, I rushed to your work, and you were one of the inspirations that actually started our business. We were like, we need to create an infrastructure that educates people, provides products if possible, and help combat all of these diseases that seem to have very similar roots. So I really thank you for that.
Yeah, well, I think, if you guys have the chance, you should fund the Single Cause, Single Cure Foundation. Because if you put money into those kinds of foundations, they support the research that is done, that fosters more information, that can, continue the process. So Single Cause, Single Cure Foundation is one. The George U Foundation is another. I mean, there's different foundations that support metabolic therapy. This is very different from NIH and very different from most of the cancer societies. So your organization could possibly contribute to the momentum that's moving forward. So you have to realize that. And that's one way to keep this momentum growing, is you fund the organizations that support the research that drives the field, not other organizations that are actually interfering with this. So that's something that your listeners, if they want to make a real difference, they can either organize the tribes or fund the kinds of research that will move this whole field forward.
We would be more than happy to do that. I've made notes of that. We already actually donate and put money into some of the educators that have been on the podcast as well. So we are more than happy. Keto Geek, our business was created as a way to actually end these diseases. So
yeah.
Thank you so much for being on the podcast.
Yeah, thank you.